Are we going to start?
Yeah, we'll start. هم شكلهم هيجوا إن شاء الله. أوكي واضح، يقولوا الصوت واضح، ممتاز. خلينا نبدأ.
Excellent. السلام عليكم. أنا دكتورة هالة، وشكرا يا أميمة على يعني الانترودكشن الجميل ده. I wish يعني if you will enjoy it, but أنا مشهور إنه ما كل الناس enjoy الهيماتولوجي. I'm working as Omer said as assistant consultant in King Fahd Specialist Hospital in Dammam. My talk today will be about sickle cell disease. In fact, الصورة دي very familiar to Umayma, which is our hospital center in Dammam. We're working as pediatric hematology oncology. We're running a service for all the benign and malignant hematology and oncology cases with stem cell transplant as well. So, as per history for sickle cell disease in the Western literature, the first description of the sickle cell disease was being first by Chicago physician James B. Harry, who noted that in 1910 that the patient of his from West Indies have some sort of anemia that characterized by unusual red blood cells that looks like a sickle shape. Later on, many tribes defined sickle cell disease and they gave it different names. Probably the most dramatic and sad name that children who come and go without them knowing the reason for that. And it's known for some African tribes for centuries, with some earliest historical report at centuries ago in 1670s in Ghana. Since after then, many advancement and progression in knowledge and treatment of sickle cell disease were followed. Around 100 years ago, they started to know that there is a relation between sickle cell disease and low oxygen. And a few years later, they know that it could be associated also with a fetal hemoglobin that could have some protective role in manifestations of sickle cell disease symptoms. And 50 years later, which is in 1984, exactly when the bone marrow transplant been introduced as a modality for treating patients with sickle cell disease, hydroxyurea was like a jump in treating of sickle cell disease, and it was being discovered in 1995 early, while it just been as a recommended modality of treatment in 2010 with very strong recommendation to be used in pediatric patients. When we look to the map for figuring the epidemiology of sickle cell disease, we can find that all the western area of Africa handling a very high risk of epidemiology of sickle cell disease, and some area like Saudi Arabia, Iran, and Middle East like India and Pakistan as well. The areas are very well known to have sickle cell disease with high incidence. The severity of sickle cell disease varies from areas to areas. Considering, like, for example, in Saudi Arabia, they have the sort of sickle cell disease is ranging from benign, which is from the eastern area, to most severe toward the western area, like in Jeddah and in Jazan, and the areas toward the Red Sea coast. In Sudan, mainly and Egypt, we can notice that they are harboring the severe type all through the country. The prevalence of sickle cell anemia in various regions of Sudan is about 0.8% in central Sudan to 30.4% in western Sudan, as revealed by available data. Al-Masiriya tribes in Kordofan and therefore represent the highest frequency of sickle cell anemia. The high prevalence of sickle cell gene was documented among population that migrated from Western Africa, reported in Al-Gadaref state in Eastern Sudan region. While in Saudi Arabia, it been recognized earlier in 1963 by some worker in Aramco, where they found that a mild form of sickle cell disease recognized in that part of Saudi Arabia, especially in the eastern part, as I mentioned earlier. And they found that there are 3 major foci of hemoglobin S gene were identified in the country. The frequency was found to be correlated to the history of malaria and the endemicity, as we will see later. Hemoglobin S gene was frequently shown to be coexist with other abnormal hemoglobin S thalassemias and G6PD deficiencies. So as by discussing the pathophysiology for sickle cell disease, it is inherited as autosomal recessive condition caused by several mutations in the beta globin gene. This mutation usually happens because of the 6 amino acid change from the beta chain from glutamic acid to valine, that yielding in resultant hemoglobin, which is hemoglobin S, having a different features or characteristic from hemoglobin A, which is a mature adult hemoglobin, in that it's prone to polymerizations with stressful conditions like low oxygen tension, dehydrations, hypothermia. It leads to polymerize like a crystals, which is very sharp endings and take the sickle shape, and that will be responsible for all the manifestation of the disease later. That, as I said, it have a number of adverse effect on the erythrocyte. And here we can see that the 6th position in the beta chain, and usually this is one of the areas that they like to ask about the pathophysiology of hemoglobin S, that the glutamine acid will be shifted to valine, and that lead to RBCs to lose it by concave shape to be into classical sickle cell shape with the sharp pointed edges that can lead easy to broken the membrane of the RBCs and here features of hemolysis later on. So as we said, as we know that all it is autosomal recessive gene, it means that both parents at least should be like sickle cell trait, or one of them or both of them could be affected. When it is both of them trait, we know that the percentage to have a normal child, it will be around 25%, and they will have 50% of their offspring will be like handling sickle cell trait, and the disease patients will be 1 in 4 chance, which is another 25%. The factor that promote hemoglobin S polymerizations, as we said earlier, stressful condition like hypoxia, prolonged delay time, the time that RBCs spend in microcirculation, just like stasis when you put like a tourniquet for extracting blood from the arm of a child or any patients. By the time that the blood circulation will be interrupted, that will promote to have polymerization and sickling process. Acidosis, high hemoglobin S concentrations, low hemoglobin F concentration, and we know hemoglobin F, which is the fetal hemoglobin, it differs from hemoglobin S and A because it's handling 2 alpha and 2 gamma chains, and we will see later how it works like a protective role from developing a sickle cell disease manifestations and complications. The pathophysiology of sickle cell in this illustrated diagram, it shows that the stressful condition, like whenever the cells will be exposed to deoxygenations, it will, as we said, it will have like a polymerizations of hemoglobin S, and that lead to sickle cell formations. Unfortunately, the smooth flow of the red blood cells, which is the normal biconcave, in the blood capillaries will be interrupted whenever there is a sickle cell shift, and that leads to microcirculation occlusions. That microcirculation occlusions will be responsible for the manifestations of the vaso-occlusive crisis in form of acute pain, hyposplenism, osteonecrosis, nephropathy, or it can lead also to hemolysis with increase in the bilirubin release, gallstones, and jaundice, or free plasma hemoglobin S lead to inactivation of the nitric oxide and increase of the reactive oxygen species, which is responsible for the oxidative damage and the manifestation of the pulmonary hypertension and leg ulcers later on. So I wish it's clear the pathophysiology, because all the things later on will be relying on understanding how the sickle cell disease physiology happen. This is another pictures. It's almost just mentioning in detail what I said before. So coming back to fetal hemoglobin, which is the normal hemoglobin from the neonate and during the first year of life, where it will start to come gradually down to normal adult range. The fetal hemoglobin, it's a major genetic modulator of hematologic and clinical feature of sickle cell disease. So it's another area that they would like to ask, what could help to alleviate or to decrease the symptoms or manifestation or complications of sickle cell disease is the presence of hemoglobin F. So in some patients with sickle cell disease have exceptionally high level of hemoglobin F associated usually in patients from Senegal, the eastern area of Saudi, Indian haplotype. They found that these patients with high hemoglobin F have a milder or asymptomatic disease. And if you can see here in the severe phenotype, where the patients that have some sort of hemoglobin F, whenever they have a more hemoglobin F with high concentration, like in entities like a persistent hereditary hemoglobin F, they usually tend to have a milder or asymptomatic phenotyping because of the diluting effect of the hemoglobin F to hemoglobin S and the prevention of polymerization by its presence. Another area it's important, and I remember that they used to emphasize on this point while studying medicine in Khartoum University, and I'm sure in all other the college in medicine in Sudan, a relation between the sickle cell disease and the malaria endemic. So if you look to the map closely, you can find that exactly the sickle cell mapping is exactly like a severe malaria. So it leads that the scientists studying what is the relation between sickle cell disease and the malaria. They found that the patient with heterozygous sickle cell gene, the heterozygous, which is not the disease patient, the patient who's carrying the gene, they are relatively protected against the danger of dying of malaria, and thus explaining the high prevalence of this mutation in the geographical area where malaria is endemic. Despite several decades of research, the mechanism of underlying protective effect remain elusive until now. They don't know whether those patients are developing hemoglobin S to protect them from endemic malaria, or what could be exactly why the plasmodium will not identify the sickle cell-like RBC to infect it. So several studies suggested that in one way or another, the sickle cell hemoglobin might get in the way of plasmodium parasite infection to red blood cells, reducing the number of parasites that actually infect the host and thus conferring some protection against the disease. But is that the scenario for the patient with homozygous sickle cell? I mean, if the patient is carrier, we know that he's protected from malaria. What if the patient is diseased? Is he also protected from malaria? On the other hand, unfortunately, the homozygous patient with sickle cell gene therefore suffer from sickle cell anemia and are highly susceptible to the lethal effect of malaria. So the vice versa, if the patient is diseased with sickle cell disease, he will develop the worst and the bad complication of malaria. And the simplest explanation to that fact, malaria makes anemia of sickle cell more severe. In addition, that the fact that the patient of sickle cell will have hyposplenism, that will reduce the clearance of the parasite. From the point of view of public health, it's important to know that malaria endemic countries patients with sickle cell, and particularly children, be protected by malaria by appropriate prophylaxis. So if they are trained, they are lucky, they will be protected, subhanallah, by default. But if they are diseased, they need special precautions and protective measures to protect them from malaria for the severe complication that could be lethal and fatal in them. أنا سريعة يا شباب ولا it's okay؟ الريت كويس أبطئ ولا it's fine, it's okay, you can cope with me ولا أميمة is it okay my rate؟ أنا حاسة إن أنا ممكن so fast.
خلينا نشوف إنهم قالوا أوكي يا هالة أوكي with them.
أوكي طيب أنت عارفاني لأنه أنت عارفاني مرات كده ما لو لقيتيني سرحت بس أعمل لي ستوب.
طيب خلاص يلا أبطئ شوية، في ناس قالوا كده واحدين قالوا كويس، خليكي في
أنا I know myself. طيب أوكي
ما شاء الله.
So خلينا تباك للnormal rhythm or rate. So let's know that in sickle cell disease very commonly associated with other type of hemoglobinopathies. It's not only sickle cell. Sometimes sickle cell will come with beta thalassemia, either major or minor. It will come with sickle cell hemoglobin C disease, or it will come with G6PD as we mentioned earlier. So what does it make a difference, and how come this affect the clinical manifestations of sickle cell disease? It based on the coherent of another hemoglobinopathy gene. For example, the patient who acquire homozygous sickle cell anemia, they are usually acquiring the most severe type of sickle cell manifestations. As it's in the first row here, they are having the most severity scale. Similar to the patient who have a beta major with sickle cell disease, they are usually having the most high severe scale. While the presence of hemoglobin C with sickle cell disease usually will minimize or decrease the symptom and severity of sickle cell disease. And what is hemoglobin C? Hemoglobin C is another entity from like hemoglobinopathy. احنا زي ما قلنا يا شباب انه في sickle cell hemoglobin S إنه position 6 it will change from glutamine للفالين، while في hemoglobin C إنه position 6 نفسه will change from glutamine to lysine. الأمينو أسيد اللي اتغير فيه هو لايسين، ده بيعمل production لهيموجلوبين C. When the patient have hemoglobin C, usually they have a milder anemia, they have some splenomegaly, they have a crystal pattern of hemoglobin C, but they don't have or prone to sickle cell vaso-occlusive crisis or a severe manifestation of sickle cell disease. So they have a milder anemia and only mild splenomegaly. Okay, you can find in their peripheral some target cells, some hemoglobin C crystals which look like rod cells, but they are usually a milder form of sickle cell. So the coherent of sickle cell with hemoglobin C giving a milder form of disease. Sickle cell with a beta major thalassemia like a trait, also it's a minor disease, while as I said with a beta null, a major thalassemia, it is very severe disease. It's important also to note that the autosomal recessive hemoglobin SS, it's usually being inherited at autosomal codominant when it came with hemoglobin SC or beta null or beta major with sickle cell disease. So how can we diagnose a patient with sickle cell disease? As per basic, the complete blood count usually will reveal the patient had some sort of anemia. His hemoglobin, the steady level will be in around 6 to 8 with high retic count, indicating that the patient had a very high turnover of red blood cells. He had been active marrow in the normal condition. In other forms of sickle cell disease, the hemoglobin level tend to be higher, which is, as we mentioned earlier, wherever the patient had a high hemoglobin F, usually their hemoglobin steady level is higher than 6 to 8. The blood film may show a feature of hyposplenism plus what? Plus the sickle cell shape. What is the feature of hyposplenism is the presence of target cell and the Howell-Jolly bodies, and I just put for you how the Howell-Jolly body looks like in the peripheral smear, and I know that you know the target cell, how does they look like. Sickling test is another way to diagnose sickle cell disease, usually in a blood film. It can be induced by addition of sodium metabisulfite, and after that you can see the proper sickling cells. Presence of sickle cell hemoglobin can also be demonstrated by sickle cell solubility test, which is a mixture of hemoglobin S with reducing solution like sodium dithronite. It usually gives a turbid appearance, while if the patient have only normal hemoglobin, which is hemoglobin A, it will be like a clear solution. So patient with sickle cell disease, when you do for them a sickling test, solubility test, for example, if they ask you and they give you 2 containers with one opaque, as we will see later, and one very clear. So the one which is turbid appearance is the patient who have hemoglobin S. Hemoglobin electrophoresis is another way that we can use a gel electrophoresis, and we use like an alkaline or acidic media to identify a various hemoglobin moving at various speed. When we put them under electric current, the hemoglobin will be moving according to their speed and charging from negative to positive into different speed, and that will make each hemoglobin at a different zone to be identified. And definitely, and of course, the most diagnostic and sensitive test is the genetic testing to define the gene itself and the abnormal mutations. So this is what I mentioned earlier for solubility test. When they add the sodium dithronite, they found that the patient who have hemoglobin S, it is usually turbid. For example, you could not appreciate the line behind the tube, while the patient who had a normal hemoglobin A, it's a clear and you could appreciate anything behind the tube. This is another example for the 2 containers. They used to like to ask a solubility test and to know which one will give you a diagnosis or spot diagnosis for a patient with sickle cell disease. Hemoglobin electrophoresis, as we mentioned earlier, when you put a patient with a drop of a patient of hemoglobin S into the electrophoresis, and usually they used to travel into a different area according to their charging, putting in our minds that hemoglobin S is a less negatively charged, so it is heavy to move. Let's say, for example, This is hemoglobin A, okay? So in a patient with hemoglobin A and hemoglobin F only, this is a normal patient with hemoglobin A2. While patient who had hemoglobin S and hemoglobin F without A, this is a typical classical pattern of hemoglobin S or sickle cell patient. While the patient who's having some sort of hemoglobin S, while there is some also presence of hemoglobin A, this is a sickle cell trait. Okay, so this is the migration direction of the electrophoresis. We better notice that the hemoglobin A is a fast migrating in the tube, so it will travel fast to reach to the top, while hemoglobin S will be left to the bottom because it is slow and less negatively charging. And I just included also how you will know the sickle cell disease and trait from the percentage. And the simple way to know that patient with sickle cell trait usually will have hemoglobin A, while sickle cell disease is only SF form, which is hemoglobin S and hemoglobin F, with a normal percentage of hemoglobin A2 like any adult or mature. Coming to the clinical picture of sickle cell disease, it's like a spectrum. It's very wide spectrum for all patients with hemoglobin S or sickle cell disease to have. It could be ranging from completely asymptomatic patient to patient with a multi-organ failure. In fact, it can touch any organ, any place in the body can be touched by hemoglobin S disease. And simple way to remember that one is the acronym or eponym for the word hemoglobin SS pain crisis, where H, which come under S, the hemolysis, Hanfus syndrome, for B, the bone marrow hyperplasia, S for stroke and skin ulcers, primarily the legs, P for pain, priapism, and psychological problems, A for the anemia, aplastic crisis, avascular necrosis, I for infections, N handling the nocturia and urinary frequencies from hypothyuria, C for cholestasis, cardiomegaly, chest syndrome, retinopathy, renal failure, renal concentration defect, S for subsequent crises like spleen, liver, and I for increased fetal loss during pregnancy, and S for sepsis. So it is a simple way. If you remember it, you could simply or in a shorter way remember all the complication and manifestation of sickle cell disease. It's important also to notice that, as I mentioned for you earlier, and I'm not sure how far they will dig you in the exam, between the difference between sickle cell manifestation and patient with sickle cell and hemoglobin C that I mentioned earlier. It's important to know that very minor differences that hemoglobin C, as I said, usually have a more retinopathy than sickle cell disease. They have splenomegaly, while you know that patients with sickle cell disease usually have autosplenicism. So to have splenomegaly, it's a rare finding in hemoglobin S. Usually they have a more avascular necrosis. So this is 3 manifestations of hemoglobin SC. Usually it's coming more than hemoglobin SS, while hemoglobin SS usually will come with all the other manifestations are more. So the retinopathy, the splenomegaly, and the avascular necrosis are more with hemoglobin SC, while they are less in hemoglobin SS. Not less, but lesser than hemoglobin SC. So coming to anemia, we know that there is many mechanisms to having anemia in sickle cell disease. The simple way that the red blood cells usually have a half-life of 120 days before they need to be replaced and being destroyed in the circulations, in the spleen, are removed. But in the sickle cell disease, usually they are dying only in 10 to 20 days. So يعني ممكن 1/6 أو 1/10 من الnormal red blood cells lifespan. So leaving a shortage of red blood cells anemia that occur in sickler patients, that the bone marrow could not replace this huge destruction of red blood cells in a shorter time. هو متعود إنه بعوضها كل 120 يوم، فدلوقتي بقت إنه 10 ل 20 يوم خلاص this red blood cells half life. So this is putting a burden on the bone marrow who could not compensate. So most of the time the patient left with a low hemoglobin with a steady level between 6 to 8. Anemia in sickle cell disease could also be from a plastic crisis. So what I mean of a plastic crisis, and I will go to see it later, that when the bone marrow is lazy and inactive or suppressed to produce red blood cells, this is what we call aplasia. Sequestration crisis, it means the bone marrow is not affected. The bone marrow is producing RBCs, but they are being more broken or distracted in somewhere else, either in the liver or in the spleen. So this also leads to destruction of red blood cells and happening, and the yield in that it leads to anemia. Hemolysis is another way to lead to anemia. in patients with sickle cell disease, as we know that they are prone to have hemolytic crisis because of the sharp ending of the RBCs whenever they pass or sequestrated in the microcirculation. It will be leading to erosions of the red blood cells membrane and hemolysis. So the four factors for anemia in sickle cell disease is the short lifespan, number one, the aplastic crisis, the sequestration crisis, and the hemolytic crisis. Okay? Retic counts and LDH and the clinical examination could give a clue to the etiology of anemia in patients of sickle cell disease. We could differentiate between whether this is aplastic, sequestration, and hemolysis, and we are going to see that in details. Patients with sickle cell disease, like other people with hemolytic anemia, they are usually requiring folic acid replacement to cope with the increased demand of RBCs production from the bone marrow. A patient with sickle cell disease whose hematocrit begin to fall unexpectedly should be checked for folate deficiency as a part of general workup. And usually that will be manifested at the picture of macrocytic anemia whenever we see that patient with sickle cell disease is starting to have a large MCV. So you have to think that this patient might need to be on folic or folic acid replacement. Most of the patients are on folic acid by default in the follow-up clinic, but some of them who are not compliant to take folic acid, you could discover that by finding the MCV is higher than normal. The aplastic crisis, it usually happens like any other hemolytic anemia and the suppression of parvovirus mainly. This is the most common cause. And usually it happens like a patient will have like progressive pallor unaccompanied by jaundice or other signs of hemolysis. Usually it is severe anemia, result in dyspnea and alteration of consciousness. And when you do laboratory, you will find that the hemoglobin level is unusually low. For example, the patient level is steady 6 to 8. He came with pallor, fatigability. The mother mentioned that he's inactive for a few days and he looks yellow to her. When you did hemoglobin, you find that hemoglobin is only 4. Okay, and you did a retic count to check out if your marrow is active and producing or the marrow itself is inactive, and the patient have a reduced retic count, which not coping with the degree of anemia, and this is exactly the hint that my patient is having aplastic crisis. So it's very important to know with anemia whether this is coming with sequestration crisis or hemolytic crisis where the retic count will be high, or it is a plastic crisis where the retic count will be low, because the management is different in the two conditions. So retic count, whenever that you have a patient with sickle cell came to you for whatever the crisis, please do a baseline retic count. It could give you a hint for the exact mechanism of his anemia. The treatment of a plastic crisis is purely supportive with transfusion to maintain acceptable hematocrit until marrow activity is restored. Unfortunately, in a patient with a plastic crisis due to parvovirus, usually he will not require more than 1 or twice transfusion بالكثير على ما الهيموجلوبين to back within few days or few weeks back to normal. So usually we'll give one, and you want to target, for example, the level of 6 to 8. You will observe him for a few days. If it's still low, then you will give another transfusion, and then that's it. You will find that the hemoglobin automatically will come back to normal steady level after a few days. While the splenic sequestration crisis is caused by intrasplenic trapping of the red cells, causing a precipitous fall in hemoglobin level and potential for hypovolemic shock. So this is the difference between a plastic and sequestration crisis. That sequestration crisis could be emergency and life-endangering and life-threatening condition. If you didn't identify the patient, you could lose him immediately within hours in the emergency room. So sequestration crisis, all the blood of the patient could be trapped and distracted, all of it in the spleen, while the patient under your eyes within 5 to 6 hours while trying to figure out what's wrong with him, what he had. If you are not fast enough to identify that the patient is going into severe splenic sequestration crisis, you could lose the patient very simply. So it is very important, and it is emergency to know this patient is going into splenic sequestration crisis. And we know how the patient usually will be identified by that. With recent decline in mortality from pneumococcal sepsis, has acute sequestration crisis for the spleen, leading cause of death in children with sickle cell disease. And it could be defined by decrease at least of 2 grams from the steady level of hemoglobin. And usually you will know that because the patient will have a very high elevated retic count and acute enlarged spleen. So it is very important while you are dealing with patient with sickle cell disease, you will teach both parents how to palpate for the spleen. They should palpate for the spleen and know where is the spleen for their child. Usually the child who have like a splenic sequestration crisis once in life or twice in life earlier, below 4 years, they will not go into stage of autosplenectomy by 4 years. We know that autosplenectomy will start to happen from the end of the first year, and by 4 years, all the normal patients with sickle cell disease, they will be autosplenized because of recurrent sequestrations and recurrent occlusion to microcirculation of spleen. So spleen itself will be involute and it will be diminuted and disappear. But when the patient have like sequestration crisis, this will delay the process of splenectomy of the patient. So it's very important when the patient comes to the OPD, you will just take the hand of the parents and put it in the tummy of their child, let them to palpate for the spleen in the right place, and they should know that whenever it starts to increase in size associated with some pain or tenderness, the child himself will indicate that he had the pain in abdominal pain. He looks very pale within a few hours. He will look dizzy, he look tired. He will look also like having some sort of jaundice. Okay, so this indicates that this is a life-threatening condition and they should bring him to emergency room as soon as possible. So if you look to the picture here, you could appreciate what is the difference between the normal spleen, how does it look like, and the sequestrated spleen when it looks large and engorged and as if it's gonna to be explode من البلاد اللي فيه. So it will be all filled with sickle cell that could be trap all the hemoglobin, and if you are not identify or treat him fastly, he could, for example, الهيموجلوبين ممكن يوصل ل 1 or even below 1. So the immediate treatment for acute splenic sequestration directed toward correction of the hypovolemia because the patient reached into stage of shock, and usually it should be within the first few hours, and transfusion should be given as soon as possible, within as fast as you could over few hours, and the very important aim while you're giving a blood transfusion for patients with splenic sequestration crisis, and please remember that because this could really save patient lives, you are not targeting a level of hemoglobin more than what is the steady level of hemoglobin for this patient. For example, the patient came to you and you could identify, yes, he comes with abdominal pain, he looks severely pale, he had splenomegaly, and he's indicating that he's having abdominal pain. So you figure out that he could be like having sequestration crisis of the spleen. You ask his mother, what is the normal hemoglobin level of your child? She tells you 8. Please don't target to correct the hemoglobin to 10. You know why? Because usually when you target the hemoglobin correction more than that steady level, whenever the crisis starts to resolve, when you give him blood transfusion, the hemoglobin will start to decompensate, the spleen will decompensate and start to release all the sickle cell back to circulation. So you will end it by having a stage of increased blood viscosity and higher hemoglobin more than 10. And this is by itself is more dangerous situation. So usually another area in treating patient with splenic sequestration, I will try to correct my hemoglobin back to the steady level of the patient. If he came to 4, I will bring him back to 8. If he came to 2, I'll bring him to his steady level if it is 7 or 6. But never target الهيموجلوبين back to 10. And I know, of course, يمكن أذكركم into how to count ال RBCs دي. It is the simple formula. I used to know it. For example, المريض جاكي وزنه 10, okay, and his hemoglobin is 6, and you want to reach for a level of 10. So you know what is the difference. For example, 6 to 10 is 4, يبقى 10 وزنه في فاكتور ثابت اللي هو 4 اللي هي 40 في another 4 جرام اللي أنا I want to cross which is 160. So this patient should be receive only 160 ml of back RBCs, nothing else. يعني ما تقومي مدينه 1 unit بتاعت الادلت 250 500. No, just target and count it carefully. So it is the weight of the patients time 4 as a factor which is اللي هي stable factor ثابت time الجرامز of الهيموجلوبين that you want to cross. شوفي انت مثلا انا 6 عاوزه اوصل ل7 هديه في جرام واحد، انا 6 انا 5 عاوزه اوصل ل10 هديه في 5، يبقى 10 في 4 اللي هو وزن المريض في 4 في الكميات الجرامز I want to cross. So please remember this way to calculate how the RBCs being calculated for patients with sequestration crisis because it's really important and it could really save lives. Another area that could sequestrate the sickle cells is the liver. So the sickle cell could be lodged in the liver and obstructing the blood flow through the organs. And the result is similar to spleen. Usually the patient will have hepatic enlargement accompanied by increase in the plasma level of hepatic synthetic enzymes. The serum bilirubin levels often will be reaching to the range of 30 to 40. Acute hepatic failure can ensure. So you will have like a picture of acute hepatitis, increase in transaminases and total bilirubin. And if you are not treated strong or rapid enough, acute hepatic failure could happen. So fluid, oxygen, analgesia are usual management interventions taken. The benefit is more aggressive measures such as exchange transfusion is still unknown or not under study. So is there any way for interaction? Anybody could come with me in this scenario? What do you think? I'll go through it alone.
They can put it in chats or they can.
So okay, and I'm not seeing the chat box. And I want to read this question, and I want you to select for me from A to E. Let's see where are we. So you receive a phone call from emergency department about a 9-month-old boy with sickle cell anemia who presented with acute onset of fever. The child is febrile. The emergency department reports that the following laboratory result. They told you that he had leukocytosis. WBC is 23,000. His hemoglobin is only 5.4. Hematocrit 74. His platelet 56. His retics count is 14%. So the questions: for what other complication of sickle cell disease should this patient receive evaluation? She should receive evaluation for fever due to parvovirus, and probably he is having a plastic crisis for this fast drop of hemoglobin. Or this patient should receive evaluation for acute splenic sequestration in setting of acute infection. Or probably this patient have allergic to penicillin resulting from systemic pneumococcal infections due to lack of pneumovax immunization, or acute development of avascular necrosis and presenting with a picture of osteomyelitis that associated with fever and high WBC count. So please put your answer in the chat box. And Umayma, if you could please see before we shift. Let me see if somebody say B, E, B, 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 E.
E, B, B.
B, 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 E, 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 B, E, E. طيب اوكي. طيب احنا في ناس between انه هي picture of infection باوستيومايلايتس وفي ناس في picture انه
في ايه؟ في
طيب اوكي يعني حس الخيارات عندنا بقت كلكم كده شكلكم حاسين انه سي دي شويه بعيده كويس which is important برضه لما تحلوا الام سي كيوز يا شباب انه try to figure and minimize your choice between two areas بالكثير. صراحه لو لقيتوا روحكم محتارين في اكثر من 2 areas معناه you need to repeat the question 3 4 5 6 مرات لما تلاقوا روحكم محصورين بين 2 choices بس. طيب for the people who said انه patient had a fever with parvovirus due to a plastic crisis, what against a plastic crisis in my patient? I totally agree with you in the patient could have a low hemoglobin because of the plastic, but usually when the patient have a plastic crisis he's having immunosuppression. So immunosuppression is not coming only to RBCs. So also his WBC count could be suppressed. Retics count, as I mentioned earlier, will be low. It will not be 14%. So this patient have reticulocytosis. He's having anemia with reticulocytosis. So a plastic crisis is less likely. Okay. Come to the option of C. Patient had acute development, not C to E. Acute development of avascular necrosis with osteomyelitis. Okay, so this explains that my patient having a picture of infection, which also I cannot say he doesn't have it, but does that explain that the patient came to emergency department with severe anemia and thrombocytopenia and reticulocytosis? Can I take these options and I be comfortable without thinking of the most emergency situation that I mentioned before? No, you cannot. So this question or this type of question, they want to know that you are a safe physician and you could figure out for emergencies and treat it on a prompt time, which is the right option for this patient is acute splenic sequestration crisis in top of acute infection, which is that the patient having severe anemia As we mentioned, reticulocytosis, it is severe sequestration crisis. On top of acute infection, it is the first thing that you have to evaluate your patient for. ممكن يطلع البيشنت عنده sequestration، ممكن ما يطلع، but it is very important when he asks you what you want to evaluate this patient for. I want to rule out إنه this is not splenic sequestration لأنه حيموت خلال 3-4 ساعات إذا ما عالجته. If it is not, then أي حاجة تانية إن شاء الله عندي شوية وقت لحد ما أنا أحلها وأعرفها شنو وأعالجها. يعني just rule out the most severe one, the worst one، وبعد كده بي كده. فدايما usually يا شباب فكروا ABC، فكروا to rule out the most severe complications. بعد ما تخلصوا انه خلاص this is not الحاجه الورس سيناريو او الورس نايت مير اللي ممكن تجي لاي واحد قاعد في الاي ار انه سبلينيك سيكوستريشن. بعد كده لا خلاص اوكي العيان ده عنده سبسيس، عنده whatever، عنده فاسكولار نيكروزيس، افتش السبب اللي عنده للانفكشن اللي عنده. هو واكيد عنده انفكشن، يعني جاي بفيفر ولوكوسايتوزيس في somewhere infection، لكن is that the most important؟ No. acute splenic sequestration على الاقل الانفكشن ممكن يديني يوم يومين ساعات، لكن السبلينيك it's a matter of few hours and he will pass away if you didn't identify and treat. So to know what is the difference between acute aplastic crisis, to sum up what we said before, and acute splenic sequestration, both of them came with anemia. Okay, both of them came with shock. It's severe, definitely. Spleen is not enlarged in a plastic crisis, it is enlarged in sequestration. Patient with the plastic crisis have reticulocytopenia because we said parvovirus will suppress the marrow, while patient with splenic sequestration have reticulocytosis. Okay, patient with the plastic crisis usually they have normal platelet, while sequestration crisis usually the patient have low platelet, like in scenario اللي راح إنه الباتient جاي بplatelet only 56 because the spleen will trap also the platelet, and I know that the spleen is the area for the platelet to die also. So the platelet will follow some RBCs and they will be trapped in the spleen. So while after I identify and I know this is aplastic and sequestration, what is the difference I'm going to do in my management? If it's a plastic crisis, then I need to go with a slow transfusion to prevent fluid overload and congestive heart failure. For example, I don't need to give a huge amount of blood and I give it immediately over like 4 hours. No, go with slow transfusion. Put in your mind, this patient may be running a plastic crisis for last few days, and he already go into decompensations with the with a heart condition. So you don't want to give it immediately. So you will push him to to congestive heart failure. While in sequestration crisis, he need a rapid transfusion because of hypovolemia, and sometimes if the patient even doesn't have a matched blood group, or it's not available right now that you have a suitable blood grouping for sequestration crisis, you could find whatever the available blood that could save the patient life. Putting in mind, it's a life-saving procedure. Another important point for important complications of sickle cell disease is sepsis. And whenever you suspect sepsis earlier, you could save lives. So it's a medical emergency again. Functional hyposplenism play a very important role in developing sepsis in such patients, and usually they are at risk of bacterial sepsis more than 400 times than normal children. 400 times the normal children that are developing bacterial sepsis. I remember one patient came to me in emergency room while I'm working as a resident in Al Askari Hospital in Riyadh. The mother came, she said sickle, she had a mild fever, and she insisted to take her to wedding. عندنا عرسة دكتورة، فبليز احنا جايين الرياض we cannot please يعني she insisted and she signed against advice. She took her child. والله العظيم أخذتها الساعة let's say 7 جابتها لنا الساعة 12 ديت في الإمرجنسي روم، جابتها ديت في الإمرجنسي روم، قالت أغمى عليها في العربية فما عارفة هي شنو، وإنه في فترة العرس كلها كانت قاعدة في الحفلة ما بتشارك البيت، على ما الأم هيصت واحتفلت لا جابت البيت فكانت it was almost dead في الطوارئ، ماتت في الطوارئ. Sepsis يعني usually could also be very severe, and it's برضو a huge medical emergency, and usually the organism that coming from the hyposplenism is encapsulated organism like gram-negative streptoneumoniae organisms. A prompt evaluation for them, focus history and physical exam, CBC retic blood culture should be taken, IV antibiotic should be introduced within the first golden hour immediately. Patient came to you with fever in sickler means ceftriaxone. This is the first line, okay? Fever in sickler means ceftriaxone. Fever with sickler with patient وكمان في حبة chest manifestation, it means I need to start by double antibiotic. So whenever fever قبل ما تبدا تفكر شفتي 38 please bring اي prescription واكتب السيفتراكسون دوزز للاطفال دول اديهم الماكسيمم دوز 100 بير كي جي بير الدوز للسيفير انفكشن واكتبها وخليها على ما يجيبوها لك. ذن ابدا انت اعمل الورك اب اعمل البلاد كلتشر اليورين كلتشرز استابلايز حط اللاين ابدا الاي في فلويد do all the other stuffs but please write الانتيبيوتيك to be ready within the first golden hour لانك انت ما عارفه اساسا المريضه اتاخرت كم في البيت على ما تجيب الطفل للامرجنسي روم وما عارف انه what he developed. طيب should I treat this patient inpatient versus outpatient? There is area that I could treat my patient of sickle cell معايا جوا المستشفى I need to admit him or I can allow him انه خلاص امشي وتعالي في العياده خد الانتيبيوتيك في الكلينيك and we'll see who are the high risk patient that need to be in hospital. So the high risk feature for children with sickle cell disease that should be treated in hospital that the patient who come in with very high fever 39.5 the infant below 1 year, the patient who missing his pneumococcal vaccine. So I'm suspecting that you could have like a pneumococcal infection on top of hypersplenism and which is usually fatal within hours. So if the mother said, yeah, we are not very compliant with vaccine, we didn't give it. So this is a high risk feature, you should admit the patient. Pulmonary infiltrate or respiratory distress, severe leukocytosis more than 30,000, a severe anemia, hemoglobin less than 6, platelets less than 150, history of pneumococcal sepsis before, if the patient used to have pneumococcal sepsis before, inadequate follow-up or non-adherent. The mother, she's not coming to OPD clinic, she's not taking aspirin, she's not taking folic acid, they have no any charting for vaccination. So you are sure this family, some sort of family, they are non-adherent to treatment, so that's better to be in hospital. And who are the patients that I could relatively be comfortable to treat them in outpatient or observing them, whom are the patients اللي هم عندهم ما عندهم نفس الكرايتيريا دي and they could I could observe them in hospital whenever they came in OPD for 30 minutes after, and I should be sure that إنه family are very well educated about the complication. أول شيء البيشنت ما عنده severe, are family educated and they have an access to hospital in case إنه السيناريو يتغير. يعني أنا طلعته البيت قلت له يلا خلاص أنت هتجيني بكرة في الأو دي السكند سيفتراكسون دوز. أنا I need to be sure إنه هو هيقدر to reach the hospital within 30 to 1 hour. إنه هو عنده طريقة لو الولد وضعه اتغير عنده access لأي hospital أو أي health center within hour. So if this is happen يعني الواحد ممكن يقول له خلاص أمشي البيت وتعالي بكرة الصباح في الأو دي إن شاء الله نكمل السكند والثيرد doses of antibiotic. So there's criteria could make you this is a high risk patient or this is a patient who could be managed in OPD. To prevent the sepsis, as we know that prophylactic penicillin should be for all the patients below 3 years. Usually we're giving 125 BID, above 3 years 250 BID. Immunization, the special immunization to sickle cell is the pneumococcal vaccine, okay, and meningococcal and the influenza vaccine. You know that, and usually they have a certain timetable for those patients. And you should be sure in any visit in OPD that he's been received the special vaccination اللي هو pneumococcal والmeningococcal والinfluenza plus الروتين vaccine for children في الشارتين بتاعهم. Education of parents very important. لازم يعرفوا significance of fever. يعني المريض ما مفروض إنه يكون parents not aware about the importance of fever and they should come to ER within few hours. They should know exactly how to palpate for the spleen and to take to measure that if the spleen is getting worsening or enlarging in size with tenderness and dyspneic child or change in his clinical condition. This is emergency feature that they should bring him to emergency immediately. Then the importance of immunization, as we mentioned earlier, for that. For the patient who usually acquire in the most severe symptom, as I said earlier, the patient with sickle cell and the beta major, beta mal, or sickle cell, usually they should bring pneumococcal vaccine, the penicillin, around 1 to 2 months of age and continue at least for 5 years. But usually you could continue more than 5 years if the patient had surgical splenectomy or the surgeon had previous pneumococcal sepsis. So there is a certain group of patients that should go beyond 5 years of penicillin prophylaxis. If he had any previous pneumococcal sepsis or he had a surgical splenectomy, then it is recommended you could go. And in a center I practice in Riyadh, usually they are giving up to 14 years, especially that the education of the families is not that much. So they are covering them with penicillin till 14 years. Coming to other area of complications of sickle cell, which is the heart and lung. Cardiovascular complications have been increasingly diagnosed due to increased longevity of sickle cell disease patients who have enlarged heart chambers, an alteration that begin in adolescence. Cardiomegaly, chest hyperactivity, and heart murmur are often present, mostly secondary to state of chronic anemia. Usually you'll find the pansystolic murmur of the anemia, hemic murmurs, the pH microcirculatory obstructions. Cardiac ion overload is postulated by an unproven mechanism in sickle cell disease. Usually I know that ion overload في الهارت it is a very important mechanism للهارت dysfunction في thalassemia patient, while in sickle cell the scenario is not the same. Still they are thinking about it, but still it's not proven to be one of the positive cardiopulmonary issues. Heart failure is uncommon and its presence associated with older age, coexistent with systemic hypertension and kidney failure. Those patients usually they could develop acute chest syndrome, and the definition definitely of acute chest syndrome or pulmonary complication in sickle cell disease usually is like a new pulmonary infiltrate on chest X-ray, and usually the patient will have a fever, hypoxemia, respiratory distress, and chest pain. And the radiographic pulmonary infiltrate, it indicating that the patient has some sort of acute chest, but in the acute stage, usually around 30 to 60% will have a normal chest X-ray. So it's not a must to say, my patient have acute chest in the initial stage to have abnormal chest X-ray. The significant that it could be ranging from mild to transient and transient in very young children with viral infection. It's common cause of hospitalization and it could be fatal, and it is one of the most causes of death في teens or early adolescence. The inciting cause for the acute chest syndrome in children is infection mainly, especially the atypical organism like mycoplasma, chlamydia, and strep pneumoniae. Pulmonary vascular occlusions, usually it happens like those patients are prone to have vascular occlusion, sometimes pulmonary embolism, silent pulmonary embolism, hypoventilations, and recently لو تتذكر يومين ما جانا patient acute chest syndrome, and we just discovered that he had like a silent pulmonary embolism when his hypoxemia not improving or even with oxygen supplement. So when we did for him a VQ scan, and we found that he had sadly a very bad picture of pulmonary embolism. Pulmonary edema and bronchospasm. When you look for the chest X-ray for sickle cell, if they will ask you usually to start with the basal changes, the X-ray will start to change from below to above. So if he came earlier, you'll find the bilateral basal, and whenever the acute chest will progress, it will come up till it can reach to picture of complete ARDS with white bilateral lungs. So the empiric antibiotic, as we said, for any patient with any chest syndromes, it's recommended to start with double antibiotic. One, the macrolides to cover for the atypical, which is azithromycin, clarithromycin, or cephalosporins as well with ceftriaxone. So the two antibiotic, whenever they have it, is azithromycin could be given orally or could be given intravenously, because I know that the bioavailability of the oral medication is just like the IV for azithromycin and ceftriaxone. Patient with fever alone, ceftriaxone could be enough. If you had another indication of sepsis like salmonella or whatever, osteomyelitis, maybe we'll see later, you need maybe to combine something with ceftriaxone. But fever, simple fever without known origin, ceftriaxone alone. If the patient had acute chest, so it is double antibiotic covers ceftriaxone and azithromycin. Often it's not needed for young children with mild disease. If the patient came only with mild chest, acute chest syndrome, and he's not deteriorating badly, saturation is not that bad, usually I will not need just a glucose antibiotic, and I need just to correct his oxygen saturation and maintain the general well-being, and I don't need to give transfusion. While simple transfusion, just to target a hemoglobin level of 10, can be given for patients who have hypoxemia, exacerbation of anemia, or even I could reach the stage of exchange transfusion if the patient came with severe disease. What I mean by exchange transfusion, that I need to transfuse the patient to change hemoglobin S to bring it down to below 30 to be in a safe level that to prevent the manifestation of acute chest syndrome. Then the preventions, usually it is by simple transfusion to prevent for the acute chest syndrome. For the patient who will go into anesthesia, I need to prepare them, usually if they are below the range, just to keep their hemoglobin around 10, and incentive spirometry, of course, can help for pre-op preventions of acute chest syndrome. Supportive care for any patient with acute chest syndrome, correction of hypoxemia. I need to maintain normal hydration. Please, there is no overhydration. Try to avoid to put the patient on 1.5 or double maintenance if the patient is acute chest syndrome, because this will worsen his hypoxemia. So just put the patient on normal hydration, strict input-output balance to know exactly the degree of hydration of the body, adequate analgesia, because whenever the patient go into a bad vasocclusive crisis as well and pain, this will aggravate the picture of acute chest syndrome. Bronchodilators for wheezes, support of ventilation. Sometimes if you need like steroid, small course of steroid, it's not a bad idea if the patient, especially known to have like a recurrent crisis of chest associated with bronchospasm. And the extreme complication of pulmonary, apart from the acute chest syndrome, is the pulmonary hypertension, which has been defined that pulmonary artery systolic pressure, in the milder it is more than 35 millimeter mercury, and if it's severe more than 45, or another definition for pulmonary hypertension, if the tricuspid regurg velocity jet is in the milder more than 2.5 and in the severe more than 3.5. And there's more than etiological factors to lead to pulmonary hypertension. It starts from the recurrent infarction that lead to lung damage, or recurrent acute chest syndrome that also leading to lung damage, or chronic anemia that the patient acquired like some sort of heart dysfunction, left ventricular dysfunction leading to pulmonary hypertension, or decrease in the nitric oxide bioavailability lead to oxidative damage and pulmonary vasoconstriction by changing the tone on the blood vessels of the lungs. And you know that pulmonary hypertension is one of the risk factors and associated with very poor outcome and death in patients of sickle cell disease. Okay, يلا take نفس وتنفسوا وتنفس هنا وناخد السكند. طيب, a second complications is pain or vasocclusive crisis in patient with sickle cell disease, and it's very common, or this is usually the most common scenario احنا بنشوفه عندنا في الأو بي دي في الإمرجنسي. Patient will come with a pain, any pain, body pain, back pain, limbs pain, chest pain, muscle pain. So triggering of pain usually is often not identified. Could be infection, inflammation, yes. Could be cooling of the skin, hypothermia, which promote sickling of cells in the microcirculation that lead to happening of the triggering of the pain crisis. Could be stressful condition like acidosis, dehydration. Site of pain could be anywhere in the body, musculoskeletal, abdominal. Physical sign present in 15% only. So the patient usually will give you ill-defined pain. It's in my back, it's my tummy, it's my legs, he cannot even indicate a certain area for pain, but he's still having the pain. Prevention, usually they found that recently hydroxyurea is drug number 1 to reduce the pain in such patients. And then you have to avoid all the causative cause like dehydrations, hypothermia, and overexertions and overheating in such patients. So when you avoid those conditions, usually this will minimize the pain. How we could treat the vasocclusive of pain? Usually you will admit the patients, you will give them non-steroidal anti-inflammatories, painkillers, opiates like morphine. You need avoid over or under treating the patients. For example, patient came with mild pain, please don't put him on morphine infusion hourly. Or patient came with severe pain, please don't only give him paracetamol. Try just to tell exactly what is the pain degree with the pain scale and give him the right analgesic for his pain. Don't underestimate, don't overestimate. There is non-pharmacological adjuvants like adjuncts like warm compressors, relaxation, massaging, correction of hydration. Usually we're maintaining normal hydration. Avoid overhydration, because you know that whenever you give like a more hydration, like double hydration, you will trigger acute chest syndrome in such patient. So usually try to prevent overhydration by double. In our center, usually we are requiring to give like normal to 1.5 maintenance to 1.5 maintenance of fluid with a strict input-output, and we are trying to avoid to give double hydration if it's not needed. Patient need to be in incentive spirometry to prevent acute chest syndrome. Then we need to define the fever and acute chest syndrome. Laxative is very important management whenever the patient on morphine, because I know that morphine will lead to very bad constipations and it will lead to very severe pruritus. So the patient should receive antipruritic management, diphenhydramine, some relieving emollients. and acute transfusion usually is not indicated for uncomplicated pain. So this is another area that they would like to ask if the acute transfusion is a part of treating the pain crisis. All the recent guidelines is not putting acute transfusion as a first line if uncomplicated pain, but however, the patient who came with severe vaso-occlusive crisis and I don't know that his hemoglobin only is far below the steady, I could just give transfusion to reach his aid, but it is not a must for uncomplicated pain symptoms. We know that the vaso-occlusive crisis in an infant below 1 year usually came mainly in fingers and toes. So it's hand-foot syndrome, dactylitis. So it could be manifested by tender, swollen fingers and toes. And you could know that because of the silent infarction that happen on those bones on long term, it could be there is some asymmetry or asynchronous of the growth of the fingers. Such patients who used to have like a recurrent hand-foot syndrome while they are young, we can find that the bone that had multi-infarctions is shorter or look deformed than the other fingers. Another important complications is osteomyelitis, and I think also this is an important area that they wanted you to know it, and they will ask you. So it's usually often occur at the site of necrotic segments of the bones. Nearly 3/4 of cases of osteomyelitis patients usually will have Salmonella species. So they will ask you osteomyelitis patient, the most causative bacteria is Salmonella. The local pain and fever are the most common indicator of chronic osteomyelitis because we know that the vaso-occlusive crisis, it is usually ill-defined pain. He will not tell you it is the exact site. But no, in patient of osteomyelitis, he will put one finger in that pain. He will tell you, on my leg, I had pain. And you will know that there is a redness, swollen tenderness, and you could identify there is area of chronic osteomyelitis or acute osteomyelitis in that area. However, the early stages, the X-ray, and even the bone scan could be completely unrevealing, could be normal. Well, however, the bone scan, recently the MRI could give you diagnosis, but the definitive diagnosis usually is a little bit invasive and it requires bone biopsy and culturing for the bone biopsy to show Salmonella growth to know this is osteomyelitis. However, we're not going to that extreme in diagnosing Salmonella. Usually we're taking like a bone scan with a sign of, WBC, white blood cells bone scans that showed that there is area of infection. It's enough. And it's important to know that because if the patient had only pain, which is due to vaso-occlusive crisis, you want to treat him for 4 to 6 weeks with antibiotic. While the scenario of osteomyelitis, you need to treat them for 4 to 6 weeks, targeting Salmonella for osteomyelitis to invade that the bone will go into bad necrosis and you could lose the whole bone if it's not treated properly. So broad spectrum antibiotic with good penetration should be used. So it's important to diagnose osteomyelitis in such cases. As we said, maybe by bone scan or the extreme is bone biopsy, but because of its invasive, usually I think most of the centers avoiding to take bone biopsy. Leg ulcers, like in any other hemolytic anemia, it could happen, and it had a mechanism of mechanical obstructions for the valve, because I know that I have a sickle cell that, as I see earlier in this lecture, it can block my microcirculation, lead to mechanical obstruction, venous incompetence, bacterial infection on top of the necrotic, the gangrenous area, excessive vasoconstriction because of increase of nitric oxide release and the inflammatory condition of the sickle cell. It leads to the change in the tone of the blood vessels to severe vasoconstriction. Decrease in nitric oxide bioavailability, which is stressful oxygen conditions, and anemia and thrombosis, all are leading to leg ulcer formation in the patient with sickle cell disease per se, and usually could appreciate them as you can see here في lower third of the leg. الحته اللي ما بتكون فيها superficial muscle وما فيها a lot of adipose tissue، بيكون usually الادipose tissue شويه والmuscle bulk is not that much huge. So the severity index for leg ulcers is ranging between stage 1 to 4. Stage 1 is only like a mild non-blanchable erythema. Stage 2, when I start to have like a partial thickness loss in the epidermis, dermis, or both. Stage 3, when I have like a full thickness loss involving damage or necrosis to subcutaneous tissue. And the extreme stage 4, when I have a full thickness skin loss with extensive destructions, tissue necrosis, damage, muscle or bones. Sometimes you could see even or appreciate you're seeing the bone. Same like necrotizing fasciitis. It will eat all the skin, all the subcutaneous tissues, all the dermis, epidermis, and you could go deep. Even the bone could be revealed in such patient with leg ulcer, very deep wound. And this is usually stage 4, and it's not needed only to treat it by medical. Sometimes it need to involve the plastic surgery people for skin grafting to close the big wound later on. The avascular necrosis is another complication of sickle cell disease. Its prevalence around 3.2 to 26.7. And usually it's manifested at the collapse of the femoral head. It occurs in 90% of patients within 5 years of diagnosis. So if you could appreciate here in this picture the chest X-ray, the normal femoral head, and you could appreciate when there is some areas of infarction of the femoral head. Usually it looks like, you see, this is the femoral head, the infarcted area that there is no blood supply in it, and it looks in the imaging like كأنها كده مأكولة كده، يعني كأنها ما بعرف اوصفها، لكن المهم شكلها كده بتحسوا فيها انه هي is not، ما بتديكم السموث اوتلاين للفيمورال هيد. فلو جابوا لكم البيكتشر دي usually this is avascular necrosis في السيكل سيل ديزيز. وput in mind انه اغلب البيشنتس of avascular necrosis of sickle cell disease will go into الفيمورال هيد replacement or surgery by their second teens، يعني بعدهم من 15 وكده most of them they will need to go to orthopedic surgery to fix the avascular necrosis because they get sometimes especially في الناس very uncompliant medications واللي عندهم severe infections it will be he will start to have like acquiring a permanent limping gait. So the prognostic factors is disease stage, lesion size, location, presence of pain, and of course the radiographic evidence of collapse as we saw it in the imaging. The most one of the most important complication for sickle cell disease is أميمة كيف التايم؟ سوري يا شباب عشان ما اكون ماخذه لكم التايم. في تايم لسه احنا ماشيين؟
خلصنا بس يعني اذا بقى لك 5 minutes ما في مشكله.
5 minutes؟ لا متفائله شديد. 5 minutes متفائله شديد جد. فاواصل ولا تحبوا نكمل مثلا مره ثانيه؟
خلينا نواصل السي كومبليكيشن طويله.
طيب نو السي ان اس لا، لكن لما ندخل في التريتمنت ربما ناخذ I don't think انه ان شاء الله نعدي بسرعه. طيب انا I will try just to point the very important point ونشوف. طيب CNS complications, you know that patient of sickle cell disease usually tend to have like a silent cerebral infarction, silent strokes, and overt stroke. They came with some sort of transient ischemic attack. They came with occlusive cerebral vasculopathy. They came with cognitive impairment. They came with reversible posterior leukoencephalopathy. طيب and manifestation of that one could ranging as we will see later from all the manifestations. It's important to me to know that the patients have a risk to develop overt, very clear overt stroke in around 10-11% of the patients. And usually I need, in order to have a primary prevention for those patients, I need to give them like a transfusion. For example, if the patient you want to prevent the patient to have overt stroke, he should be in a chronic transfusion program, like a monthly transfusion program. This is, what I mean by primary prevention. I mean that the patient have imaging changes, but still he doesn't have a stroke. He doesn't have neurological manifestation. So I give him chronic transfusion program, and there is a lot of trials that confirm that after 1 year of chronic transfusion program, if I put him on hydroxyurea, is not inferior result in chronic transfusion program. So as primary prevention للstroke, للovert stroke, أبدأ chronic transfusion وأمشي الهيدروكسيوريا. Let's say إنه المريض جانب hemiplegia. Could I put him on hydroxyurea وأكون مرتاحة إنه he will not develop it again? No way. Whenever the patient had overt stroke, the only way you could give him اللي هي الكرونيك ترانسفيوجن بروجرام أو البون مارو ترانسبلانتيشن. Is it clear يا شباب؟ أعيد عليكم مرة ثانية. If the patient had MRI changes for stroke or MRI changes, let's say whatever infarction, you want to prevent him to have hemiplegia, you could go with chronic transfusion program as first primary prevention. After 1 year from the chronic transfusion, studies done on many trials, and they found that hydroxyurea could replace the chronic transfusion وفي successful إنه هي تمنع إنه يحصل له stroke. If the patient وصل لدرجة إنه جاو stroke, nothing could prevent a secondary stroke مرة ثانية غير إنه يكون على chronic transfusion program أو إنه أنا أعديه BMT. طيب نجي للمريض اللي عنده silent stroke. طيب silent stroke currently frequently like 20 to 40 neurocognitive academic impairment only. So I will give them secondary prevention for them هو chronic transfusion. Primary prevention for them is unproven or still unknown. طيب بس انه secondary prevention for them to develop a silent stroke is a chronic transfusion program. It's the most important to be مع overt stroke و understand exactly الرول للchronic transfusion versus الهيدروكسيوريا. طب الsymptoms usually from paresthesia to gait to hemiparesis, seizures, headache, symptoms, deterioration of vision, academic achievement problems, neurocognitive impairment. I will go through this fastly. Usually they found that عندهم twice the rate of school difficulties. 80% they have cognitive impairment. 35% عندهم known to have deficit في academic skills. And usually if the child came with very poor school performance بتقول لك الولد ده ما بعرف في المذاكرة، ما ماشي كويس، البنت ما بعرف مالها، من مرة في السكول كلها ما خالص. This is an indicator that you could have silent infarct and indication to do for him transcranial Doppler and imaging. Diagnosis usually by transcranial Dopplers, by CT brain, by MRI, by MRA, by angiography, by PET scan, and by MRS. For transcranial Doppler, children with sickle cell disease at high risk of stroke. The risk is highest in children with elevated blood flow velocity in the distal internal carotid artery اللي هو باين هنا في الصورة. طيب والبريكسيمال ميدل سيريبرال ارتري. وافتكر دي برضه من الحتات اللي كانوا بيحبوها في الام سي كيوز. What is the most blood vessels being involved في الستروك اللي هو الميدل سيريبرال ارتري والديستال انترنال كاروتيد ارتري. وas we said انه whenever there is a changes chronic blood transfusion program if implemented in timely fashion انه انا بدي له تقريبا كله 3-4 اسابيع ما بسمح للهيموجلوبين to be down انه ينزل. At the same time I'm maintaining hemoglobin S low. Usually it could reduce the risk of stroke as much as 92%. I know that الcut limit لأنه المريض لما أعمل transcranial Doppler عشان أقول إنه abnormal ونورمال اللي هي 200. Please remember it يا شباب. Transcranial Doppler more than 200 it is usually abnormal and it needs me to do imaging to check if there is any abnormal or silent infarction or overt infarction. Sickle cell disease sometimes associated with entity of a disease in brain called moyamoya disease. 43 of patients usually will develop moyamoya collaterals on imaging. What is moyamoya؟ إنه البلاد فيزلز بتجي تعمل زي نتوركينج كده شبكة تتشربك مع بعض، فدي بسموها moyamoya disease or syndrome associated with كل المانفستيشن اللي احنا شفناها، academic impairment, الهيميباريسيس، الفرونتال headache, السيجرز. How can we treat it? We'll try to prevent it. Prevent it as we said. أول مع early symptoms مع chronic transfusions. طيب ممكن sometimes مع الهيدروكسيوريا زي ما قلنا. bypass surgery once إنه happen لما نوصل للمنظر ده it can be diagnosed nothing could reverse الشكل ده إلا إنه يمشي لbypass surgery وإنه بيعمل أكسجين. طيب acute presentation neurological patient with sickle cell who develop neurological event within less than 3 days. طيب I will not go يعني deep in that. The issue that if the patient he develop acute stroke or any manifestation, exchange transfusion is very important to be run in the first 3 days. Let's say in the patient already he passed the first 3 days, but still he had worsening deterioration of symptoms. Again, go again and give exchange transfusion. If he's beyond that 3 days and the patient have no worsening of his symptoms, then you could consider chronic transfusion program, and it is case by case. So I will pass by these critical thinking questions for sake of time, and I just also to pass by sickle cell eye disease. It's important to know that sickle cell can lead to retinopathy, and usually there are 2 forms. Non-proliferative retinopathy and proliferative retinopathy. In children, usually the retinopathy associated with sickle cell disease is in 30%. It is non-proliferative, which could present with the salmon patches, as you could appreciate it here in the first picture, or with schisis cavitis, or iridescent spots or black sunburst. In adults, usually they are having like a form of proliferative retinopathy. And it's important also to screen من العمر 10 سنين وانت طالع للpatient by ophthalmology, regular ophthalmology screening for evidence of retinopathy to send them for annual retina involvement or retina examination by ophthalmologists. Genitourinary complication is another important, and usually it being started by the most common manifestation we see in emergency, which is periabism. It's persistent, unwanted, usually painful, unrelated to sexual activity, erection of the penile area. It happens in 30 to 45% of the patients. 2 to 5% of the hospital admission is due to periabism in sickle cell disease in such patients. The pathophysiology usually will have like obstruction of the venous drainage of the corpora cavernosa, increase the intracavernous pressure, ischemic and irreversible ischemia, and lead to later on to fibrosis and impotence if it's not been treated early. Significant changes at cellular level noted at 24 hours, and usually the onset happen early morning while the patient will used to have like a natural erection, and if he had like a periabism due to sickling, usually it will be more severe during the morning time or during the rapid eye movement stage of sleeping. Usually the patient will have like a home management way if it's simple and less pain, like having oral analgesic, very well hydration, warm bath or shower, as a child to have a frequent urination to empty the bladder, and oral pseudoephedrine. For prevention, they found that nightly pseudoephedrine or liberolide or biclotomide, which is one of the gonadotropin releasing hormone analogs, it could prevent the painful erection. And if it's prolonged more than 4 hours, then this is again emergency, because it can lead to severe dysfunction and impotence in future. So it needs to be treated by IV analgesia, IV hydration, pseudoephedrine, rapid aspiration and irrigation. And it's important to know that in children, it's better to avoid shunt procedure for the risk of impotence in future. Acute transfusion is not shown to be helpful. And I want to tell you important point in this patient, exchange transfusion may be harmful, it's not helpful. يعني أنا ممكن أدو simple transfusion, but I will try to avoid exchange transfusion because it's associated with Aspen syndrome. So what is Aspen syndrome? Aspen syndrome is a synonym for association of sickle cell disease with periabism and exchange transfusion and neurological event. Early recognition and aggressive medical management resulted in complete reversal of neurological sequelae. Usually it will be manifested by severe headache, initiating symptom of this complex, and the ensuing neurological event ranging from seizure activity to requiring to extreme picture that even he will require ventilatory support. The proposed pathophysiology for this Aspen syndrome اللي هي إنه المريض يجيني periabism أقوم أديه exchange transfusion. It related to cerebral ischemia after an acute increase in percent of total hemoglobin concomitant with decrease in the percent of hemoglobin S and subsequent release of vasoactive substance during subsidence or diminution of swelling of erection. When you give exchange transfusion نقص عليه بسرعة هيموجلوبين S، عملت بسرعة ريليز للهيموجلوبين في السيركوليشن هيموجلوبين S، it will go للسريبرال، اعمل اوكلوجن للمايكرو سيركوليشنز، وده بيعمل شنو؟ سريبرال اسكيميا. So it is known that الاكستنج ترانسفيوجن في المرضى بتاعنا الاسبن في المرضى بتاعنا البريابيزم can lead to Aspen syndrome. So please try not to consider exchange transfusion and go with simple transfusion as much you have it a space. The renal complications for such patients, it also a wide range, and I will go to these pictures. It starts in the first decade by concentration of the urine problems like reversible hyperthermiuria and polyuria and early proteinuria, while from 10 to 20 years they will start to have irreversible hyperthermiuria. All the urine will be diluted. They will start to have renal tubular acidosis, and they will start the picture of hematuria. And then later on, by 20 to 30, the patient will start to enter the end-stage renal disease, especially if it is complicated sickle and untreated, and not controlled sickle disease all through his timing. He will usually range from very reversible to very end-stage renal disease. So the first manifestation is during concentration issues, reversible hyperthermiuria, and the extreme at 20 to 30 decade is the end-stage renal disease. And also, like as I mentioned earlier, for retinopathy, patients should be started to investigate it for proteinuria by age of 10 years by urine dipsticks frequently to check for early proteinuria in such cases. Hepatobiliary symptoms complications. As we know that chronic hemolysis caused by condition often cause formation of gallstones that migrate and block the common bile that lead to acute abdomen. Complications of gallstone usually ranging from cholecystitis, pancreatitis, cholangiopathy, and gallstones could trigger acute sickle cell crisis. Laparoscopic cholecystectomy on an elective basis, a well-prepared patient becomes a standard approach to symptomatic patient. However, the symptom attributed to cholecystitis often persists after cholecystectomy. You know that the patient will go into stage of post-cholecystectomy syndrome. He will still having the same pain and everything. However, you are sure that the gallbladder is out, but this will be lasted for a few months initially till that syndrome will be resolved. So the treatment for such patient is to do for them cholecystectomy. It's very important also. We know that in such patient to evaluate for the presence of the spleen, if he's going into a splenic crisis or something, because you need to sometimes to consider doing both surgery at one time together. This is only abbreviation for the other liver issues. For growth and development, we know that usually the patient with sickle cell, they have their weight being affected more than height. So they are thin but tall patient. They are thin. The weight is compromised, the height is not that much compromised, and the reason for poor weight is not understood, but it is likely to present increased caloric requirements of elevated resting energy expenditures related to the anemia, increased bone marrow activity, and the cardiovascular compensation. And this is exactly, it shows how that the weight is being affected more than height. So coming to mortality, the peak incidence of this was between 1 to 3 years of age, and generally in pediatric patients is mainly due to infections, while in adult patients, acute chest syndrome play an important role in that one. The probability for surviving to age of 29 years was 85%. For those with hemoglobin SC, probability of surviving to 20 years is about 95%, even higher than sickle cell. And we know that usually the patient of sickle cell, ladies around 58 years lifespan, and males usually around 52, little bit shorter than the females. But now with BMT and with recent modalities, definitely I'm sure that the lifespan and the mortality will be different completely. So when we come to treat sickle cell disease, which is the last part of my lectures, that we know that to reduce the mortality, the early diagnosis is important. Starting from newborn screening, I have to diagnose the patient within the first 3 months to start his vaccination table. I need to start him on prophylactic penicillin as I mentioned earlier. الصغار بنديهم زي ما قلنا 125, بعد كده بنديهم 250 BID لحد الفيرست 5 years unless إنه البيشنت عنده previous pneumococcal أو splenectomy. إذا كان عنده allergy للبنسلين, please give him Bactrim or Septrin. Vaccination, as we said, the most 3 vaccines are important: pneumococcal, والmeningococcal, والinfluenza vaccine. The 4 main treatment options available for sickle cell trait is the blood transfusions, the drug treatment, the BMT, and the gene therapy. So per transfusion, that you know the indication is the acute anemia and arrest disease process and prevent complications. Simple transfusion, which is top-up transfusion, usually I want to target a hemoglobin level of 8 to 10, and usually we need to avoid over transfusion to avoid the risk of viscosity and worsening of manifestation. Exchange transfusion, if the patient had like acute stroke or severe acute chest syndrome or multi-organ failure syndromes, I need to go exchange transfusion. Or if the patient have a rapid clinical deterioration of his clinical condition, and usually if the patient came with complication that I cannot give simple transfusion, for example, he came to me with a baseline hemoglobin around 9, there is no room to give patient with hemoglobin 9 top-up transfusion to reach 10. So whenever you are already, his steady hemoglobin level is in a range of 9, so you can go with exchange transfusion, putting in mind that there is no room for top-up transfusion. Chronic transfusions, as we mentioned, the program usually it comes with a stroke for primary and secondary prevention, recurrent acute chest syndrome, and frequent pain. Management is usually monthly, every 4 to 6 weeks, usually from 6 months to indefinitely. He will continue on that based on his clinical condition and manifestation. The pre-transfusion, hemoglobin S is targeting below 30. I want to give him a monthly transfusion just to keep hemoglobin S as low as 30. hemoglobin S negative back RBCs should be selected every time for transfusion. And you know that such patients are very prone to develop alloimmunization to different blood groupings. So extended antigen matching is very important in such cases to be sure that he's having the right blood grouping without acquiring alloimmunization against various donors. Partial or automatic exchange could be done both ways, either manual or automated. The main complications, you know, for transfusion, as we know all of us, is the iron overload, the alloimmunization, and the infection, especially that expenses والhospital stay والissues الثانية مع البلاد transfusion. So this is the curve that showed that whenever you give over transfusion, you are increasing the risk of viscosity and the stroke. Another drug that been introduced and now it's very well recommended for all the pediatric patients with sickle cell disease is hydroxyurea, which works through a ribonucleotide reductase inhibitor that increase hemoglobin F as a main function. It indicated usually in a patient with hemoglobin S, and usually they offer it after 9 months. And I think there was a trial which is a baby hug. I think it's a baby hug trial where they give hydroxyurea for starting from 9 to 18 months, and they found that it reduced the vaso-occlusive crisis and the acute chest syndrome to great degree, while they found that there is no difference in splenic or renal functions, but at least the vaso-occlusive and the acute chest syndrome could be delayed much or could be prevented by hydroxyurea introduction. The dose of hydroxyurea, I'm usually starting by 20 milligram per kg, 15 to 20. You will increase it in a step-ladder way gradually. Over every 8 weeks, you will increase about 5 per kg per day لحد ما نوصل لحد 30 ل 35 milligram per kg per day. Or I start to have like any symptom of toxicity. شنو السيمتوم بتاعت التوكسيسيتي للهيدروكسيوريا؟ neutropenia, neutrophil less than 1,000, platelet less than 80, hemoglobin drop more than 2 grams, or absolute retics less than 80, then this is a feature that my patient is reaching the maximum level of hydroxyurea, and I have to adjust my level of hydroxyurea back down again. So the maximum could reach 30 ل 35 until I reach a favorable response or I reach a toxic sign, as I mentioned them already. Neutrophil count less than 1,000, platelet less than 80, hemoglobin crossing 2 grams below, and absolute retics more less than 80. So this is mainly the same efficacy for hydroxyurea. It showed that it decreased, as I said, the vaso-occlusive crisis, acute chest and hospitalization stay, and the transfusion amount, right? And it may prevent organ damage. So hydroxyurea is very well recommended now for all the pediatric patients with sickle cell starting from 9 months. I will pass through this and this one fast and come to BMT. So the hematopoietic stem cell transplantation remains the only curative treatment currently used for patients with sickle cell disease. The first successful, as we mentioned earlier, it's in 1984, and it has complications including CNS hemorrhage, which is the most important in patients with sickle cell, and especially those who have history of strokes. That's why any patient of sickle cell disease who will go into a BMT, you need to put them in anticonvulsants medication for at least the first 6 months of post-bone marrow transplant to prevent the neurological sequence or events in such patient. And in our center, we are required to give them Kebra for around 6 months until we stop all the immune suppressant therapy. Then we'll consider to withdraw it down, but not less than 6 months, please. So such patient can have hypogonadal function, graft rejection, acute or chronic GVHD, prophylactic anticonvulsant treatment, as we said, should be maintain them during the first 6 months while the patient is still in some sort of immune suppression. Gene therapy is the most directed approach to cure of sickle cell disease and rely in correction replacement of the patient on defective beta globin gene with normal gene, genetically engineering autologous hematopoietic stem cell. Offer 2, they will take it from the patients and they will modify it by entering يمكن هنا في picture. The vector will be in the retrovirus or lentiviral. They will insert it in the patient own cells. Then they give the same patient like some sort of marrow conditioning chemotherapy. After that, they will give him the vector infusions, and that lead the patient to start to produce a normal beta globin gene, which lead to production of hemoglobin A and delay or stop the production of hemoglobin S. So the approved new targeting therapy, I think maybe this is the last slide, is apart from the hydroxyurea, is new some medication. Better you heard about them. So if they ask you to be aware, like L-glutamine اللي هو الاسم التجاري له إنداري. This is new drug. It works على vaso-occlusive crisis and it is عنده antioxidative effects. Alcrizanlizumab is another. بيشتغل على البيتا selective inhibitor, beta selectin, and usually it also have على vaso-occlusive crisis. Voxylator ده بتساعد على إنه برضو stop vaso-occlusive crisis and it work إنه to keep red blood cells في oxidized form, so it will prevent polymerizations of the red blood cells. So Voxylator only one it stop polymerizations, while Alcrizanlizumab and Indari it help to stop vaso-occlusive crisis through the other way. في الريسنت دراج برضو كان اسمه شنو ريفيبانسل ولا منو؟ Rivibancil, I guess. It was Rivibancil also. It is a pan-selective, a pan-selective للبيتا selectins والE-selectin, and also it helped to work على vaso-occlusive crisis. So عشان بس تكونوا سمعتوا بها يعني in case. This is another slide. I will send the lecture لأميمة to share it with all of you, so you can pass through it whenever you need. It shows you how you could target each stage من mechanism of sickle cell disease with recent medications, including, as I said, Alcrizanlizumab and alvoxylators, والإنداري والhydroxyurea. I won't go through that again, I think, and also for critical thinking. So as prevention, that we need to know that the only way to prevent sickle cell disease is genetic counseling. So whenever that the newly wanted to marry couples, they came to genetic counseling. However, we saw that many cases in Saudi Arabia, they told them that both of you are trait, بس هو مصر دي بتعمليه وانا لازم اعرسها وما بعرف، وفي النهايه بيجيبوا الاولاد كلهم سيكلز. It seems انه حتى genetic counsel without انه family education انه هم aware انه risk of having sickle cell disease will not help. The genetic counseling, beside a very good education, is helping. Unfortunately, we found that a level of education والperceptions الdisease itself والway of inheritance is not important. يعني كان بيجينا واحد بيقول لي انتوا قلتوا ريسك 1 ل4، طب الولد الكبير جاته السكر، الثاني ليه جاته؟ يعني عشان تفهموا انه الريسك في كله pregnancy 1 ل4 وكلهم ممكن يكونوا affected او كلهم normal. It takes يعني كده time. It's need very important يعني community education about the sickling and genetic counseling. Neonatal screening as early as possible to prevent the complications, start the vaccinations, al-ospin, and family be aware about the complications, fever, and all the stuff we mentioned before. Best of luck and thank you guys. لو عندكم سؤال إذا كان في تايم ناخده، وإذا ما في تايم ابقى شكرا.
متوقع ممكن يا هالة نديهم الإيميل يرسلوا فيه الأسئلة، الصراحة مرة جميلة.
الله يديك العافية أميمة. I wish إنه أنا ما كنت سريعة لأنه أنا I'm sure most of the people will sleep while I'm talking.
لا بس مرة جميلة صراحة، يعني very
الله يديك. واحد عنده سؤال ممكن أرسله على الإيميل، أنا أو بيشور إن شاء الله إن أنا أرد عليه.